Good morning, good afternoon, and good evening, and welcome to today's Introduction to Forensic Substance Use Evaluation. I'm Livia Eriger, and I'm the Deputy Director of ISSUP, the International Society of Substance Use Professionals. I'm here today with Dr. Erin Norton, the Executive Director of the National Board of Forensic Evaluators, a not-for-profit board headquartered in the United States and officially endorsed by the American Mental Health Counselors Association. The National Board of Forensic Evaluators provides training, certification, and professional advocacy for licensed mental health professionals specializing in forensic mental health evaluation. You will learn much more about their work and the trainings and certification that they offer in today's webinar. I first heard Dr. Norton present at last year's NADAC conference, and I was very impressed by his presentation. And after the conference, we started exploring a potential partnership between the National Board of Forensic Evaluators and ISSUP. And as our members are regularly inquiring about training opportunities, we thought it would be excellent to partner with the National Board of Forensic Evaluators to offer our members training opportunities to become certified forensic mental health evaluators. I would like to thank Dr. Norton for the collaboration between the two organizations, and today marks actually the first joint activity of our new partnership, and we're excited to see so many of our members have joined to learn more about forensic mental health evaluations. For those of you who are new to ISSUP, we're an international membership organization with over 32,000 members who work in prevention, harm reduction, treatment, and recovery support. We provide our members with access to training and credentialing, with opportunities to build networks, share knowledge, and learn from each other's work through our website, our virtual and in-person events, and through our national chapters. I would like to invite you all to join ISSUP so that you can access the wealth of information and resources available on our website and share your knowledge and your skills with other ISSUP members. Membership is free, and you can apply to become an ISSUP member on our website. Before we get started, I would like to go over a few things so you know how to participate in the webinar. At the end of today's presentation, we will have time for a Q&A session. So please send us your questions through the chat function on the GoToWebinar control panel. You may send in your questions at any time during the presentation. We will try to address as many questions as possible during the Q&A session. And for those of you who want to rewatch the webinar or share it with your colleagues or friends, the recording will be available on our website and on the ISSUP YouTube channel. I would now like to formally introduce our speaker, Dr. Erin Norton. Dr. Erin Norton is a licensed mental health counselor and licensed marriage and family therapist with certifications in addictions, alcohol and drug counseling, rehabilitation counseling, clinical mental health counseling, trauma treatment, forensic mental health evaluation, forensic behavioral analysis, and forensic psychometry. As mentioned earlier, Dr. Norton serves as the Executive Director of the National Board of Forensic Evaluators. He is an assistant professor of instruction at the Department of Mental Health, Law and Policy at the University of South Florida. He serves as Southern Regional Director, Ethics Committee Liaison, and International Counseling Task Force Chair for the American Mental Health Counselors Association, and Chair of the Government Relations Committee for the Florida Mental Health Counselors Association. He is the consulting editor for AMHCA's The Advocate magazine. He co-authored the forensic evaluation section of the AMHCA standards for the practice of clinical mental health counseling, authored the proposal for AMHCA's clinical mental health specialist in forensic evaluation credential, and served on the expert panel that created the standards and written exam for the Florida Certification Board's certified telehealth practitioner credential. He has 20 years of experience as a psychotherapist and clinical supervisor, was awarded Mental Health Counselor of the Year by the American Mental Health Counselors Association in 2016, Counselor Educator of the Year by the Florida Mental Health Counselors Association in 2016, Researcher of the Year by the Florida Mental Health Counselors Association in 2019, and he was awarded AMHCA's Public and Community Service Award in 2020. He is an experienced writer, presenter, and trainer, and has been published in several academic journals and professional magazines in the counseling profession. We are pleased and thankful to have him with us today to share his knowledge and with our members. And now over to you, Dr. Norton.
All right, thank you, Olivia. And I'm very grateful for the opportunity to be able to present today for ISSUP. I believe very strongly in your mission and your purpose, and I'm very passionate about quality substance use treatment and certainly evaluation, which is so important in terms of helping to connect people to treatment and as we're going to be talking about today, helping authorities to make important decisions related to substance use, whether in criminal cases or civil cases. So I'm really pleased that a lot of ISSUP members are interested in a topic like this and willing to spend some time talking about it today. So welcome everyone. So I'm going to start off we have some handouts that are uploaded as PDFs in your GoToWebinar control panel. You'll see them under handouts if you click on that arrow there next to handouts. Not all of the handouts are there because we're limited with the number of handouts that we can show on the screen at one point. There we go. I think hopefully my screen is sharing right now. So you can get the additional handouts by clicking or by scanning this QR code with the camera on your phone. And also, I'll go ahead and paste into the chat box real quick a link that you can use also. That's another way to get the additional handouts. So let me do that very quickly here if I can. Okay, there we go. In the chat box, I can do it, I think.
Yes,
Oh, except for perfect. I only sent it to the...
That worked, yes.
Okay, it only let me send it to the organizers and panelists though. So if
Olivia, we have sent it now on to everyone. Yes.
Oh, perfect. Thank you. I appreciate it. All right. So then we have a lot of information there. In the handouts, you'll see the slides from today. You'll see a checklist, a DSM-5 substance use disorder checklist, which we'll introduce later on today. Something called the adult interview guide from ASAM. It's a guide that you can use for a verbal interview as part of a substance use evaluation or a psychosocial assessment. So we'll talk about that resource and some of the changes that are coming up with the new ASAM criteria, which we'll learn a little bit about today. This is a sample evaluation packet that I give to clients who I'm conducting an evaluation with. There's a flyer about our upcoming certification workshop with ISSUP. And this is an article in AMCA's The Advocate magazine on 3 reasons to consider adding forensic evaluation to your practice. So some of these resources we'll be talking about in greater detail in just a moment here. Let me just change these settings here. There we go. Okay. So also my email is on the left-hand side on this screen, aaron@nbfe.net. So if there are questions we didn't get to today, you come up with a question later on, feel free to send me an email and I'll respond to you. Sometimes it might take me a few days to respond if I've gotten backlogged with a lot of emails, but I'll be glad to respond to you, and I will if you send me an email. And what I hope to be able to accomplish today, I always have more slides than we're going to have time for, and that's okay because it means you'll have lots of information that you can look at on your own after the training today. But what I'm hoping we'll be able to cover in the time we have today is identifying the diagnostic criteria for substance use disorders. And if we have time, we might even apply those criteria in a case scenario. Preparing you to conduct a clinical interview to determine if a client meets diagnostic criteria for one or more substance use disorders. Hopefully you'll be able to identify some tests that detect subtle attributes of substance use disorders with built-in validity scales, because oftentimes clients who are being evaluated for forensic purposes are not always going to be very forthcoming or very accurate historians with information about their substance use. And you hopefully will also feel prepared to use collateral sources for additional information. If you don't know what collateral sources is, that's fine, because we're going to be learning about it today. And then finally, applying the ASAM treatment criteria when formulating treatment recommendations. Now that is, the ASAM criteria is, as the name implies, it is a tool developed in the United States, and very commonly embraced here in the United States. It is used in some other countries as well, but even if you don't use the ASAM criteria where you're at, and maybe you use other criteria, it's still a great model from a conceptual perspective, I think, for determining levels of care and then trying to find out what kind of care is appropriate for a specific client that you're meeting with. One of the reasons we like to do these kinds of trainings is that there are a lot of mental health professionals all over the world who have their own unique areas, their niches, their specializations, and many of these mental health professionals are undertrained on diagnosing or evaluating or assessing for substance use disorders. Now, I can remember I used to work for the state government in the state where I live for many years, and we would order psychological evaluations for many of our clients. And what I discovered was that none of the psychologists that we had in my region felt like they had particular expertise in substance use disorders. So when they're doing an evaluation, they would use some very sophisticated tools to try and identify whether somebody has maybe a psychotic disorder or a bipolar disorder or a depressive disorder or a learning disability. But when it would come to substance use disorders, they would just ask somebody a few questions and then move along and not really conduct any quality assessment tools in their evaluations. So one of the things that I tried to do when I worked for that government agency was try to help get these psychologists to get more advanced training in evaluating substance use disorders, to access more tools that they could use for assessing for substance use disorders, and to try and recruit more psychologists who had that expertise. So just know there are a lot of mental health professionals who lack particular training and experience with evaluating substance use disorders. And that's why I think the trainings like the one that we're doing today can be so important. But there are a few other reasons I also think this kind of training is very important. I think clients deserve thorough and objective evaluations, especially when we're dealing with clients who are presenting in criminal justice settings. They are involved in maybe a criminal case or a civil case. The decisions that evaluators make, the opinions that they offer, can have tremendous impact and can affect a large number of lives, including public safety. And so we really, I think, need to have people providing these evaluations who have that advanced training and expertise. And I also think that clients who are involved in the criminal justice system still deserve to be treated with dignity and respect. And in some cases, I've seen evaluation processes that just don't seem to honor the kind of dignity and respect that we like to afford to people that we're evaluating. It's very difficult for people to feel comfortable disclosing the kind of information that we're trying to get from them. Quality evaluations are so important for public welfare and safety. And also, when we do not do a very good job of providing evaluations or expert witness testimony in the courts, then our field loses credibility in the legal system. So my hope would be that professionals who provide evaluations for the courts or offer opinions about cases or who testify as expert witnesses in court, that they would do so with a tremendous sense of professionalism and in a very ethical way as well. So it's a very important topic. So we'll start by jumping in with diagnostic criteria. Okay, so there are different sets of diagnostic criteria for substance use and addictive disorders. And I'll focus on two of them today. One is the DSM, the Diagnostic and Statistical Manual of Mental Disorders, which is commonly used in the US and Canada and Australia. Some chartered psychologists in the United Kingdom will use it. But it is predominantly used, I think, in the United States. And then we'll also talk about the International Classification of Disorders, or ICD, which is very commonly used in European countries as well. And the ICD, and I'm sorry, I think on the previous slide I had a typo. I say International Classification of Disorders, but it's actually of diseases, ICD. And the ICD started in 1893, and originally it was a tool that was being used in Canada, Mexico, and the United States. But then it was given to the World Health Organization in 1948. And that is still to this day who manages the ICD, the World Health Organization under the United Nations. And currently, the newest edition is the ICD-11, although we're not yet using it widely in the United States. We're still on the ICD-10. Some countries have moved on to the 11, though, and others are still using the 10th edition. The DSM, on the other hand, was created by the American Psychiatric Association in 1952. And today, the current edition is the DSM-5-TR, which just came out last year and has 299 psychiatric diagnoses in it, including all of the substance use and addictive disorders. And for a little side-by-side comparison of the DSM and the ICD, just remember the DSM, it's produced by the American Psychiatric Association, and they own it. And the ICD is produced by the World Health Organization, which makes it free and openly accessible to professionals all over the world. And one thing that is so critical about the ICD and why it's so important is that the ICD creates codes for all kinds of different conditions and disorders, whether they're substance use disorders or they're other mental health disorders or any kind of biomedical or physical health condition. And then these codes provide a universal language. So no matter what language people speak all over the world, they know that when a certain code's being used, they know what that code means. And it makes it so much easier to do international research and to collect international data about prevalence of disorders and trends in the development of different disorders. Well, the DSM has codes next to every disorder also. And those codes are the same codes that you'll see in the ICD. So both of these diagnostic systems use the same codes. They may have slightly different titles for some disorders, and the diagnostic criteria will tend to be more detailed in the DSM than we'll see in the ICD, but they use the same codes and they're essentially talking about the same disorders in that sense. Speaking of which, both of these resources have all these categories of different substances for which you can look up different disorders, like intoxication, a substance use disorder, a dependence diagnosis. In the DSM-5 and the ICD-11, we see pretty much the same substance categories. There are a few differences. They're not major. Like, for example, in the DSM-5-TR, we have a category of stimulants and includes amphetamines, cocaine, but in the ICD-11, they separate cocaine from other stimulants. So relatively minor difference. The ICD has a special category for synthetic cathinones. We don't see that in the DSM-5. And in the DSM-5, hallucinogens includes PCP or phencyclidine, but in the ICD-11, dissociative drugs like ketamine and PCP are separated from hallucinogens. And in the DSM-5, for some reason I don't fully understand, we use the word tobacco, whereas in ICD-11, the word nicotine is used. So there are these slight differences, but overall, the same substances can be categorized in very similar ways using these two different tools or models. So let's start with the DSM-5-TR. For people who use that resource or are interested in learning more about it, we have this chapter called Substance-Related and Addictive Disorders in the DSM-5-TR. And it includes 10 separate classes of drugs that we showed on a previous slide, but it also has gambling disorder, which is not a substance use disorder, but is now conceptualized as an addictive disorder in the DSM. And there are other conditions that might get added in the future to this chapter that aren't substance use disorders, but are addictive processes, such as internet gaming disorder and some behavioral addictions like sex addiction, exercise addiction, or shopping addiction. We don't know whether these things will be added in the future, but certainly there are people who think they should be added and are trying to amass enough research to sort of convince the APA that those conditions need to be added to this chapter. So we'll see. But we're not going to focus on those areas today. Now, a few definitions of addiction. There are a lot of definitions of addiction out there. I've got two on this slide, one from the National Institutes of Drug Abuse here in the United States, and also the American Society of Addiction Medicine. But I think when it really comes down to it, pretty much every definition that I see for addiction involves repeatedly participating in behavior that activates reward circuitry in the brain. So I continue to participate in a behavior that's very rewarding, even though it's causing significant negative consequences for me in major life areas. I continue with this behavior, even though it's causing clinically significant problems, impairment or distress. And that's really, I think, the bottom line with addiction and with addictive disorders. So then in the DSM-5 TR, we have our substance-related and addictive disorders chapter, and we start with substance use disorders. These are disorders that some people would call addiction, or in the case of alcohol, alcoholism. But in the DSM, we use the verbiage substance use disorders, which is thought to be a more neutral term than terms like addiction or dependence. And we define substance use disorders as a cluster of different symptoms. They can be cognitive, involving thinking, behavior, or physiological symptoms that indicate that a person's using a substance despite significant related problems. And then we have 11 different symptoms of substance use disorders, which are categorized into 4 groupings. Those 4 groupings are impaired control. That's the first one. And impaired control means that I'm having a difficult time controlling my use of a substance. It might be that I'm using a lot more of the substance than I intend to or plan on, or it's absorbing a lot more time than I want. It might be that I'm trying to quit or cut back, but I'm unsuccessful in doing that. It might be that my use of this substance also triggers substantial craving, strong compulsion, strong desire or urge to use a substance that's very difficult to control. The second grouping is social impairment. And this refers to the different ways that my substance use can interfere with my ability to get along with other people, to function in a society with other people, or to establish and maintain healthy relationships and connections with others. So we see, for example, difficulty with major role obligations and responsibilities, the question of whether people can really rely on me or depend on me when it comes down to it, and whether I'm continuing to use even though it's causing problems in my relationships, and whether there are important activities that involve my connections with other people that are being given up or cut back on because of my substance use. The third grouping is risky use. And this is when somebody's using substances in a physically dangerous or hazardous situation. In the United States, the most common symptom in this category will be driving under the influence of a substance. And outside of major metropolitan areas in the United States, there are many places where people are they really need to have their own vehicles in order to get from one point to another because things are so spread out. And it is, if somebody goes, for example, to a bar or a pub, and then they drove to get there, then they're probably driving to go back home. And so we certainly have our share of substance-related problems on the road involving driving. But there are a lot of other ways that this set of criteria could be met. For example, let's say that somebody they're intoxicated and they're hunting, they're handling a firearm, and there have been accidents, hunting accidents, because people were impaired while they're using a firearm to hunt. So those are just a couple examples. In the fourth category, we have pharmacological criteria, and that refers to tolerance and withdrawal. To have tolerance or withdrawal, a person has to be using a substance repeatedly, probably daily or almost daily, for a long enough period of time for their system to habituate to the use of a substance. So that basically means that if I keep introducing to my brain a chemical that changes brain chemistry, then within a relatively short period of time of regular use, my brain will start to make accommodations or adjustments to try and function as normally as possible, even though there is a mood or mind altering substance within the brain. It will, for example, raise or lower distribution or manufacturing of different neurotransmitters to try and adjust for the presence of the substance. And then if I suddenly stop using the substance or cut back on it, then I can experience withdrawal while my brain tries to recalibrate and get a new sense of how to regulate its own internal chemistry to make up for the use of the substance. There's a lot that I could say about tolerance and withdrawal. It's a topic that I love to talk a lot about, but we only have so much time today, so I won't go into too much detail. But tolerance, it takes more for me to get the same effect I used to get from less, or I'm using the same amount as I used to, but getting less of a feeling or effect from it. And withdrawal is I'm using it daily or almost daily. I stop or cut down on my substance use, and then I experience some distress or some problems with my functioning connected to the brain trying to recalibrate. Okay, I won't go over prevalence of substance use and addictive disorders, but you have a lot of statistics on your slides that you could look at later on if you like. The one thing I would say, though, is that substance use disorders are so much more common than a lot of people think they are. I guess a good example here is that almost 1 out of every 3 people in the United States will develop an alcohol use disorder at some point in their lives, even if it's a mild alcohol use disorder. And I have seen a lot of evidence that similar numbers exist in so many other countries throughout the world. And a lot of that data is actually in the DSM. They do provide international data in the DSM as well as data from the United States. Okay, I think we can move on to talking a little bit about the drug-crime connection before we get into how you can more effectively collect information as part of an evaluation. I just think it's good to cover some of this information. It's not surprising that in the forensic arena or in the legal system that we would have quite a need for substance use evaluation, because individuals who use substances do tend to report higher levels of involvement in criminal activities. And they're more likely than people who are not using substances to have criminal records. And people with criminal records are much more likely than others without records to report being drug users. And crime rates increase proportionately with increases in drug use. In other words, as substance use rates increase in any region, crime tends to increase along with it. There is a correlation or relationship between substance use and crime. And Goldstein, in a very popular article in 1985, proposed 3 different mechanisms or models for this relationship between drugs and crime. The first is psychopharmacological crime. And he proposed that people under the influence of a substance will have altered ways of thinking and have changes in their impulse control. And so they might do things they normally wouldn't do when they are sober or not using a substance. And some of those things will involve illegal activities sometimes. So the first thing is somebody's under the influence of a substance, and then they make decisions they normally wouldn't make and do things they normally wouldn't do that could be criminal. But the second mechanism is economic compulsive crime. And this means that substance users will commit crimes in order to afford their substance use. I, for example, when I was in my mid-20s and I was a grad school student, my apartment was burglarized. Everything I had of significant value was stolen. And the person who burglarized my apartment, as it turns out, was actually a very close friend of mine, somebody who I'd known since we were kids. But the problem is he developed an addiction. In his case, he had a pretty severe addiction to benzodiazepines like Xanax, and he owed a drug dealer money. And so in his desperation, he broke into the homes of people that he knew and stole the things they had and then sold those possessions in pawn shops to try and pay off his drug dealer. So that is an example of economic compulsive crime. But the third category is systemic crime. And this would refer, for example, in the case of illicit or illegal drugs, there oftentimes will be groups of people who sell these drugs on the street or in the market, so to speak. And these groups will oftentimes be criminally involved groups because by definition, they're involved in a criminal trade. And so you might have violence between competing groups that are trying to sell drugs and trying to maintain certain territories. And that's a third category, systemic crime. So these are three different ways to explain the relationship between drugs and crime. Now, an important finding, though, is that, very often I hear people say, somebody's not going to get help unless they hit rock bottom. And I think that's true to a degree, but the problem with that saying is that some people use it to argue that if you require or mandate people into treatment in connection with a criminal charge, then they're not gonna change unless they're ready to change. But what we're often not thinking about is that once somebody gets into treatment, even if the only reason they went to treatment was because of a criminal sanction, then they often develop the motivation to change while they are in treatment. Because what's usually happening in treatment is that they're repeatedly showing up and working with people who genuinely care about people and their well-being, and they're being exposed to information, and they're sometimes having profound emotional experiences, and they're learning things that they may not have known before. And in that process, they often develop the motivation for change. So surprisingly, there is a substantial amount of evidence that mandated or required treatment is as effective as voluntary treatment separate from the legal system. Okay, so now having talked some about some basic information about substance use disorders, I want to move on to forensic evaluations versus clinical or therapeutic evaluations. And what are these two things and how are they similar and different from each other? Forensic evaluation is when a professional, in this case a substance use professional, is offering professional opinions for the court or for other legal proceedings. And it sometimes gets fuzzy about whether an evaluation is forensic or clinical. So, for example, in the United States, certainly not all, but a majority of people who seek substance use treatment do so under pressure from somebody else. It might be because they were arrested and they have a criminal charge and it's been required of them to go. Or it might be because they violated a drug-free work policy at their place of employment and their employer is requiring them to participate in some kind of treatment in order to maintain their job. Or it might be because family members have insisted that they go and will not provide them with financial assistance or help unless they get appropriate treatment. But whatever the reasons might be, a large number of people seek substance use treatment under pressure from others. And sometimes those others are part of the legal system. And when that happens, when the legal system is referring people to treatment, they need professionals in the community who can meet with somebody and provide a quality evaluation or assessment to offer a well-informed opinion about what kind of treatment would be appropriate for a particular client in a particular scenario. And broadly speaking, that's what we're talking about when we're talking about forensic evaluations. But in forensic evaluations, these are evaluations that are very different than the kinds of evaluations that a lot of behavioral health professionals will conduct with people who are voluntarily seeking treatment without any pressure from others. For one, in a forensic evaluation, the client's self-report, what they tell you, is just one data point. See, if I had a private practice for psychotherapy and somebody just comes to see me because they want to get some help, then I'm going to, in the first appointment, get to know them a little bit, find out what's going on with them and what their concerns are and what their needs are, and then try to figure out what kinds of approaches might be good to use with this particular client or patient. But in a forensic evaluation, what the client tells you cannot be fully trusted, because so often people will present for these evaluations and either intentionally not give you accurate information or unintentionally not give you accurate information. So you really can't go just by what the client tells you in a forensic evaluation. I'm going to come back to that in just a moment here. But so many standards in our field require us to base our diagnoses and our assessment summaries on multiple sources of data. What the client tells you is one source, but what are the other sources of data that you're going to use when you're trying to get a clearer picture of whether somebody has a problem with substances, what the extent or severity of that problem is, and then what kinds of treatment they might need? And it's difficult because denial is part of the addictive process. For me to keep doing something over and over again that's causing me significant problems, I have to have some way of distorting the truth, some way of feeling or thinking or convincing myself that it is better for me to do this thing than to not do this thing. And so here are some terms to think about related to this phenomenon. The first is positive impression management, and that means that a client is exaggerating how good things are for them. This means that a client is trying to portray themselves in a more positive light than the actual picture might warrant. This would be, for example, people who deny having a problem with alcohol or other substances, even though they've had significant problems connected to their substance use. They will exaggerate how good things are in their life. Negative impression management, though, is when clients exaggerate how bad of a problem they might have. Now, for substance use disorder evaluations, we might think that most people are going to be involved in positive impression management. If anything, they're probably going to be denying that they have a problem when they really have one. But sometimes we do see negative impression management with substance use evaluations. I'll give you an example of that. I used to work in a corrections program, and in this program, essentially people would be in jail and they're awaiting trial. And they might hear that there's this professional who's going to come into the jail and interview them. And somebody, like maybe a cellmate, will tell them, when that person comes, tell them that you smoke crack cocaine every day. Because if you tell them that, then they might be able to get you into a residential substance use treatment program, and you can go there instead of going to prison for maybe a few years. A short period of treatment in the community instead of going to prison. So then sometimes people will lie and say they have a worse problem than they really have in order to avoid going to prison. So that's an example of negative impression management. But also a lot of clients are going to have cognitive problems. They're going to have some deficits or some impairments in their ability to remember things, or to be what we call an accurate historian, to accurately report information to you, and some just lack insight. They aren't connecting some of the consequences of their substance use to their substance use. So these are just a few reasons why we cannot fully trust, of course, what a client tells us in a forensic evaluation. So if you can't fully trust what the client tells you, then where do you get your other information from? Remember I said earlier that in forensic evaluation, we have to draw from multiple data points, not just client self-report. So these are 4 categories of data that you can collect as part of your evaluation to help inform your opinions for the courts. The first one is the clinical interview, and that is when you are interviewing the client. There are people who interview in a very unstructured way, and some people use very specific tools with specific questions to conduct their interviews. Those might be called structured or semi-structured interviews. But the bottom line is that that category of data is all about what the client is telling you. The second category of data is records. For this category, you would try to find what kinds of records might exist related to this client that might give you a clearer picture about whether they might have a problem with substances. I'm going to offer you a few examples of that. I've had occasions when during the clinical interview, the first data category, a client might tell me, no, I've never had any medical problems that are connected to using a substance. I've never had a medical problem related to alcohol or any other drug use. So then I might get records from hospitals that they've been to, or records from their primary care physician, their family doctor or family physician. And then when I go through those records, I might see that 2 years ago they had a stomach ulcer, and that the doctor thought that the ulcer was related to heavy alcohol use and advised or recommended to the client that they stop drinking alcohol. So the client may have told me during the interview that they've never had a medical problem related to their alcohol use, but when I pulled their medical records, I found out otherwise. A second example I'll give you is that a client told me that she had been hospitalized within the past year, because I ask everybody that I evaluate about their hospitalization history. And I asked her what the hospitalization was about, and she said it was about a sodium deficiency. So then I accessed records from the hospital, and she's right, it was about a sodium deficiency, but the part that she didn't talk about was that the sodium deficiency was caused by chronic and severe alcoholism, and that she'd been hospitalized multiple times related to her heavy alcohol consumption and referred repeatedly to residential treatment, which she continued to not go to. So you can see how sometimes getting these records can be very helpful as another source of data. But I also will tend to review arrest records. I'll read what law enforcement officers wrote when they responded to a scene and look for evidence that somebody's actions might have been substance related. Sometimes I'll access transcripts from public hearings or from court appearances. And if the person's had any kind of treatment in the past, whether it's substance use treatment or it's psychiatric treatment of some kind, I'll access those records. And I'll often find that there are discrepancies between what they're telling me during the clinical interview and what they've told other professionals in the past over the years, or what other people have documented. So that's the second category. The third category is collateral information. And this is when you interview other people besides the client or the patient. You might interview spouses or partners or family members, neighbors, employers, 12-step sponsors. One time I did an evaluation for a man who was in the military, and I interviewed his commanding officers because I was trying to find out if there were any concerns about his behavior in active duty that might suggest any kind of a problem with alcohol or other substances. So this is when you interview people besides the client. And then the fourth and final category of data is objective test data. And this is when you use tests that are specifically designed to give you clues about whether a person's self-report might be accurate and about whether there's a statistical likelihood of them having a problem with substances, even if they're denying having a problem with substances. And it can also include the use of drug tests, whether urinalysis, drug testing, hair tests, fingernail tests, blood tests, etc. So these are 4 categories. And so the problem I see is that sometimes professionals will evaluate a client and they'll offer opinions to a court or to a judge or to an attorney, and they've only used one of these 4 categories of data. They've only done a clinical interview, but they didn't review records, they didn't interview anybody besides the client, and they didn't use any standardized and normed tests that are designed to detect signs of substance-related problems. And so that is a significant concern to me, because as I mentioned earlier, what the client tells you is very often not going to be fully accurate when you are providing forensic substance use evaluations for the courts. Okay, so the clinical interview, let's start with that part of the evaluation. There's your informed consent. This is when you meet with the client, you explain to them what you're here to do, you make sure that they know that the information that they share during the evaluation could play a role in the outcome of their case, and you solicit their agreement to participate. You explain to them the process and the way that it works. Now, this is going to vary because in different places around the world, there might be certain laws and regulations about informed consent and what it looks like and what it's supposed to include. We're very heavily regulated in the United States, so we have an awful lot of information about what informed consent is supposed to look like, and it also varies from state to state in our country. You know, we have 50 states and then some US territories, and different states have different laws and rules, so there's a lot of regulation here about informed consent. And then you would actually discuss, well, what led up to this referral? Why are they here? What happened? How did they get involved in this case to begin with? Why did somebody refer them to this evaluation? What kinds of questions are we trying to answer in this evaluation? And then there's a diagnostic interview where we try to determine whether somebody has one or more substance use disorders, maybe what their treatment needs are. And then there's biopsychosocial assessment. And this is when we're collecting information about various areas of somebody's life that could play an important role when it comes to recommending a particular treatment intervention. So I am going to skip to, I've got several slides here that you can look at later if you like, that show an example of informed consent, the way that I tend to do informed consent. But again, it might look very different wherever you are practicing, because there might be different laws or rules in your country or your province or your state or region or county that govern informed consent and what it's supposed to look like. So this is just an example that you can look at later if you'd like to. It's an example of what I do in my state here in the United States, but ultimately it's your responsibility to know the informed consent process and any regulations about it wherever it is that you practice. So in discussing the circumstances related to referral, we're asking the client about who referred them and what they were referred for and where this thing happened at and when it happened and how it happened. You're using active listening skills, repeating back things that you've heard the client say, demonstrating that you're hearing them, you're listening, and that you're understanding them. You're giving them an opportunity to share their story and get the information out that they really want to get out. Oftentimes for me, when doing forensic substance use evaluations, clients will spend several minutes just trying to convince me of essentially how they don't have a problem and how they don't really need to be here, and this is all a giant misunderstanding and so forth. So I'm very used to hearing that, and it's important to be very patient and to truly listen to them and try to understand what they're saying during this process. We're also ensuring that we really know what questions we're supposed to be answering that the judge or the court or the probation officer want to be answered in this evaluation. That's very critical that we make sure that we're asking the right questions. So let's move on to the diagnostic interview. We're trying to determine if somebody has one or more diagnoses. The first part of that diagnostic interview is obtaining a thorough substance use history. And I tell clients, I understand that you may not fully know the answers to these questions. And sometimes you might be guessing or estimating what the answers are. But that we're trying to get their best estimate when we ask questions about their substance use history. For each category of substances like alcohol, cannabis, cocaine, etc., I'm going to ask what substances the client used, how they used it. Is it something they smoked, snorted, inhaled, drank, how much they would use, what they liked and disliked about using that substance, and under what circumstances it was used or when it was used. So for example, I might ask a client Do you remember about how old you were the first time that you drank alcohol? And they'll probably give me an age, and then I'll ask them, when was the most recent drink that you had? So that gives me a start point and an end point in terms of the period of their life of consuming alcohol. And then I tend to go back to their earlier years. Let's say that they tell me, I probably first drank alcohol when I was 16 years old. Then I might ask them, okay, when you were 16, you were in high school, probably. So when you were in high school, on average, about how often did you drink alcohol? And then I might ask them, on days when you drink, what's the least number of drinks that you would have each time? And then I would ask them, when you were in high school, what would you guess would be the greatest number of drinks that you would have in a day? And then I would ask them what they think the average number of drinks was and whether that changed as the years progressed. So that sounds like a lot of information you're collecting, but what you're trying to piece throughout the person's life is when the use of a substance started, how frequently it was being used, and any patterns or changes in their use history over time. I'm going to move past this slide. And if they endorse a symptom, we need to find out when it was happening, how often, and for which substances. That's part of the diagnostic process. And if a client gives me yes, an answer to a question, I'm going to ask follow-up questions to get more information, to dig a little bit deeper and get a clearer picture of what their substance use looked like. So here are examples of questions that can be asked during a diagnostic interview. And I'm going to draw from the DSM-5 TR diagnostic criteria for a moment. Part of our criteria, the first of the 11 symptoms is the substance is often taken in larger amounts or over a longer period than was intended. So I might ask questions like, was there ever a period of time in your life when you were using one of these substances more than you planned on? Or have you ever thought to yourself something like, I'm just going to spend 2 hours at the bar today, but found yourself staying a lot longer? Or have you ever thought to yourself, I'm just going to have 2 this time, but found yourself drinking more than that? So what I think is important is when you're looking at the diagnostic criteria, whether it's in the International Classification of Diseases, the ICD, or it's in the DSM, don't just read the words out of the diagnostic manual. Those words are very formal and they're very scientific sometimes, and most people are not going to relate to that wording. So you want to use common everyday language to reword symptoms and give examples, and then ask if clients relate to those examples. I think that's critical. So just to give you an example of that, let's take let's see if I can find it here real quick. Here it is. If I ask a client, have you recurrently used substances in situations in which it's physically hazardous? Most clients will tell me no if I ask it that way. But if I ask a client, have you ever driven when you can feel the effects of alcohol? Well, then they'll say yes to that question, even though they just said no to the question about whether they've used it in a physically hazardous situation. There are a lot of reasons for why they would answer no to one question and yes for another. But what I'm trying to get at here is don't read out of a manual. You have to find out using common everyday terminology, how to ask questions to determine if a client meets a particular criterion. So what I've done is I've given you lots of examples of questions that you can ask and how you can word things. And we're not going to have time to go through them all right now, but you have them here in the slides to look at later if you would like to. In the DSM, we categorize the severity of somebody's substance use disorder based on the number of symptoms that they've had in the same 12-month period. So it's mild if there are 2 or 3 symptoms in the most recent 12 months of use. If there are 4 to 5 symptoms, we would call it moderate, and 6 or more would be severe. That's a general guideline. Okay, now what I want to do is skip forward to the ICD and just give you a little bit of information about how the ICD might be a little bit different than the DSM in this area. There are blocks in the ICD, and there are disorders due to substance use or addictive behaviors, and then there are disorders that are simply due to substance use. And these disorders due to substance use, would be the same thing as the substance use disorders that I was just showing you in the previous slides from the DSM. So there is some additional information here about the ICD-11 criteria that you can look at later if you'd like to. I'm trying to pay close attention to time. We don't have too much time left before I'll probably want to see what kinds of questions you have. So I want to cover a few things before we start to get into questions and answers. One is, remember that one of those 4 categories is about the use of, well, actually, let me backtrack for a moment. In the clinical interview, one thing that we're trying to do is a biopsychosocial history. We're trying to collect a lot of information about many different areas of somebody's life. Some of these areas won't face value have anything to do with their substance use. You might ask a client about their legal history, their arrest history, or you might ask them questions about their relationships, who they live with. You might ask them questions about whether they have any unusual financial stress or what their work history looks like. Because a lot of these variables are going to play a role in matching them to the right kind of treatment. There are some structured tools available that people can use to conduct some of these interviews. Here's one, the ISAM Criteria Assessment Interview Guide. This is free for anybody to access as a PDF, and it's in your handouts folder. And I'm going to show you it just very briefly here as an example of a full biopsychosocial assessment. It starts off with, this would actually be a good point to tell you about the 6 dimensions, the ASAM criteria. As a biopsychosocial assessment. The first dimension is acute intoxication or withdrawal potential. Here we're trying to find out if a client might experience withdrawal if they suddenly stopped using. So you're evaluating somebody and you might refer them to a treatment program. And maybe when they go to this treatment program, they're going to be required to be completely abstinent from all substances. But what if they're drinking heavily every day and they're using benzodiazepines like Xanax, and they've developed a significant addiction to those substances? If they suddenly stop using alcohol and benzodiazepines after heavy and prolonged use, they could experience a medical emergency. They could have a seizure, for example, and it's even possible for them to die from withdrawal from either of those 2 categories of substances. So it's obviously very important that you know if there are signs that a person will experience a medical emergency if they suddenly stopped using. That will play a role in what kind of treatment intervention you recommend. You might recommend they go to a medical detox facility to be medically supervised while withdrawing from a substance, for example. So here are all your questions. A lot of the things we talked about before: the substance, when they last used, the average that they used per day, what their uses looked like in the past 30 days, how frequently they've been using, and how they've been taking the substance in. And you'll see that for each of these substances. And then we move on to questions to try and get a sense of whether they've experienced withdrawal in the past or whether they might experience withdrawal now. Now, some agencies and practices will involve a physician in assessing dimension 1, acute intoxication or withdrawal potential, but some won't. And then based on their answers to these questions, there's a coding system. It might range from none on one end, which is no signs of withdrawal or intoxication, to a very severe risk on the other end, where somebody might need to go to the emergency department in a hospital immediately. So this is an example of a tool. We won't be able to go over everything on this today, but I just want you to be aware of this tool and opportunities to get trained more on the use of this tool through an organization like ASAM. The second dimension is biomedical conditions. So here we're finding out what kinds of medications they might be taking, whether they have any medical problems to be aware of, what some of their needs are for treatment. Because let's say that a client is an insulin-dependent diabetic, and you're going to refer them to a residential substance use treatment program. Does that program have medical staff? Is it easy for a client to access their medication in that appointment so that they don't experience a medical emergency? This is part of the reason why it's important to know about biomedical conditions. And then again, you have your risk rating system. The next category is co-occurring mental health or psychiatric conditions. If a client, for example, had schizophrenia and needed access to antipsychotic medication, then it's going to be important that if you refer them to a treatment program, that is a program that is equipped to work with people with chronic and persistent and severe mental illnesses, and that would have psychiatric services available and integrated into that program somehow. And then another category for dimension number 4 is readiness to change. This is whether the client recognizes a need for change based on whether they perceive there to be problems connected to their substance use and how ready they feel to make that change. And then the next category, dimension 5, is whether they seem to be at high risk to relapse in the near future or to continue using if they haven't stopped using yet. And then the final category, the final dimension is dimension 6, and this dimension is going to be about their recovery and living environment. If, for example, you are recommending outpatient care for somebody, but when you conduct your assessment, you find out that they don't have any supportive friends or family, that maybe the people they're close to all use substances in a problematic way, and maybe they live right next door to their drug dealer, or their roommate has a heavy addiction, it's going to be much more difficult for them to quit and stay quit, given their living environment and their social connections, than it might be for somebody who has a very intact support network in the community. So this is an example of a tool that some people use for that interview they're conducting with a client. And these are the 6 dimensions we just went over. We won't have time to talk about the different levels of care, I don't think. I want to show you one more thing before we go into questions. Actually, 2 more things. We already talked about records reviews. These are examples of records you might review, and then things you're looking for when you're reviewing those records. And tests. This is something I wanted to show you. So let me go back to this slide. In the United States, I favor a tool called the SASI-4, the Substance Abuse Subtle Screening Inventory. And the reason I really like this measure is that it is designed to provide quantitative data about a person's level of defensiveness. So there are certain items on the test that if a client is being honest and accurate, and they're not being defensive, they will tend to endorse, because most people endorse these items if they're being honest. And just to offer a hypothetical example, there could be an item that might say something like, I am not always truthful. Well, most people, if they're being fully honest, will at least slightly endorse that statement. They'll say, well, yeah, I've sometimes been untruthful, so I can't say that I'm always truthful. But a person who is maybe more defensive and they are trying to portray themselves in a more positive light than the actual picture would warrant, they might deny that they're ever untruthful on that statement and say, no, I am always truthful, and then move on to the next question. And if enough questions are answered like that, then their defensiveness scale rises, and then you have evidence that you can't fully trust their self-report. Now, to get more complicated, if you combine that scale with some other scales, then you can show an increased likelihood that they're being defensive about their substance use specifically. Also, these measures will have certain questions that on face value don't have anything to do with substance use, but for reasons not fully understood, people with substance-related problems will answer them differently than others will. And those are called subtle attributes. And so sometimes you'll have a profile that will suggest that somebody has the kind of personality that would make them more likely to have a substance-related problem, even if they're denying having a problem related to substances. So those are just a few examples of how a tool like this can be helpful. There is a version available in Spanish, and it's available for both adolescents and for adults. But again, this is a tool that was developed in the United States, and I'm not fully aware of how much research has been conducted on the SASE-4 in other countries or with people that come from various cultures to a place like the United States. So there really is often a challenge of finding what quality tests can you use that are normed for the population that you're working with. The Maryland Addiction Questionnaire is another one that I really like. You only use it with people who have a substance use disorder because it is normed for people that you already know have a problem. And it gives you a lot of information about appropriate treatment fit. It might give you information about whether somebody seems really defensive and resistant about treatment, whether they're highly motivated or not to get help, whether they have a lot of social anxiety and maybe they might struggle in a group setting, whether they might have a co-occurring mental health disorder or a psychiatric problem that might need to be addressed along with their substance use treatment, and whether they're having intense cravings. So it really has a lot of useful information when you're trying to determine what kind of treatment might be a good treatment fit for this client. And there are lots of other tests. Here are some tests that are commonly available at no cost, including the audit. Actually, if I'm remembering correctly, the audit is a tool that the World Health Organization likes to publish and provide information about. The drawback to these three tools, to all of these tools on this screen, is that none of them have what we call validity scales. So they won't give you information about a client's level of defensiveness or whether they're being inconsistent in their self-report. So these tools are really more useful when you have a client who maybe is fairly accurate in the way that they're reporting information. All right, so what I'm going to do at this point, instead of talking about urinalysis drug testing, is I'm going to skip to recommendations, and then we'll go into questions and answers. When providing an evaluation for the courts or for other legal proceedings, oftentimes you're going to be asked to answer questions about what kind of treatment a person might need who might be involved in the legal system. And I am offering an example of a list of recommendations that might show up in a report. The first recommendation that you see here is a fictitious client, Mr. Romero. Mr. Romero should successfully complete a minimum of 16 weeks of ASAM Level 1 outpatient substance abuse treatment focused on relapse prevention in a dual disorder enhanced program that can simultaneously address his co-occurring anxiety and depressive disorders. Well, that's a mouthful, but I want to point out a few things here. Number one is I've given a duration recommendation. Now, there's a lot of data published that substance use disorders, the treatment episodes should not be less than roughly 90 days or 3 months. In the DSM, for example, somebody's not in remission unless they've gone for at least 90 days without any symptoms of a substance use disorder other than possibly craving. So what concerns me is sometimes people will say, yeah, Mr. Romero should go to treatment, but they don't tell the legal authorities that they're providing this report for what kind of treatment, how long that treatment should be, what level of care it should be. So the person might not get an appropriate or adequate level of treatment, therefore. This is somebody who I thought needed at least 4 months or 16 weeks of treatment and who I thought could be treated on an outpatient basis, but that they needed to be in a program where the treatment professionals had expertise in mental health disorders such as anxiety and depression, and not just in treating substance use disorders, because this client had co-occurring depressive and anxiety disorders. So I thought they need to address all three together: the substance use, the anxiety and the depression, and the complex relationship between those three problem areas. The second thing, as I wrote, Mr. Romero should maintain abstinence from alcohol and illicit substances throughout his treatment, as evidenced by participating in random monthly urinalysis drug tests. Very often, clients will not accurately self-report whether they have relapsed or used while they're in treatment. So most treatment programs here in the United States will use some kind of urinalysis drug testing to try and corroborate or verify a client's self-report of whether they're using substances. So I build that recommendation into my list of recommendations. The third recommendation, Mr. Romero should comply with any aftercare recommendations offered by his treatment team. I put this in because sometimes somebody will complete, say, residential care that was recommended, and then the staff and the residential program will say, okay, we think it is medically necessary for you to now go to intensive outpatient. And if I don't write in my report that they should comply with those recommendations down the road, then the ball might get dropped down the road. And then the final recommendation, to ensure continuity of care, Mr. Romero's treatment provider should review this report as part of the admission and treatment planning process. One of my greatest frustrations is when somebody provides a quality substance use evaluation for the courts, and then it gets sent off to a judge, and maybe a judge orders somebody to participate in treatment. The client goes and gets the treatment. They show up in front of the treatment professional. The treatment professional asks, what brings you here? And they say, I don't know. I don't even have a problem. I don't know why they referred me. And that treating professional doesn't have access to the same information you have access to. So it's important that the person treating the client has a copy of your report and knows what you know, given that you did such a thorough job. All right, so now we're going to go into questions and answers, because I know we have very limited time left, but I also have here on the screen some information about the upcoming certification workshop for individuals who are mental health professionals who in the regions in which they practice, they can diagnose and treat mental disorders, including substance use disorders. They may be interested in pursuing certification with the National Board of Forensic Evaluators. And if you are, we have a certification workshop that is 8 hours long in 2 4-hour segments on November 1st and 8th in partnership with ISSUP. And there are other requirements for certification aside from attending the workshop, including a written exam and an oral examination, but it's all there on the website, and you can either visit this site or use the flyer in your handouts or use this QR code to go to that registration page and learn more. We'd love to see you there if you're interested in pursuing certification or just getting the training, even if you don't want to be certified. All right, so Olivia, I'd love to hear if there are any questions that have been posed so far.
Yes, thank you very much, Aaron, for this excellent presentation. Yes, well, just at the beginning, just wanted to share that the webinar has been very well received. I've been reading the comments coming in. There's actually more comments than questions, but we do have a couple of questions. Just before we start with the questions, I guess some people might have joined a bit later because they're asking for the slides and for, you know, the handouts. So I just wanted to again say that we do have the handouts and there's a link in the chat. If you go to the chat, you can actually click on that link. I don't know if Aaron, if you want to share the QR code again, you know, that slide that you
Sure.
had, maybe that'd be great because we've had several comments and questions about the notes and slides. So we'll share that QR code again. And then, yes, and yeah, again, more comments coming in. Wonderful presentation, very, very helpful, very insightful, very informative. So I just wanted to share those comments with you as well. Let me just go to some of the questions. So we had a general question that came in pretty early. What are the criteria for working as a forensic substance use evaluator?
Good question. That's going to vary depending on where you practice in the world, because this is an international group. And one of the challenges with doing international presentations is there are so many laws and rules in so many countries and regions that it's hard to answer that question. What I can tell you is that here in the United States, we're very heavy on licensure. So people who can diagnose and treat substance use disorders in pretty much every state have to either have a license to practice as a mental health professional, or they might have to have a certification. So I can tell you, like in Florida, where I'm at, for example, if to be a forensic evaluator, you're going to need to be a licensed mental health professional. And then you're also going to have to be able to ultimately convince a judge or other stakeholders that you truly are an expert. And there are many different ways to do that. One of them is to have a CV or a resume that has a history of all of your training in substance use, any certifications that you have that show that you have special expertise in substance use work will be helpful. But throughout the United States, you typically have to be licensed and be able to show that you have some kind of specialized training. That's going to be different in some other countries. In some countries, there is no license to practice, or there might be certification, and there might be requirements about education levels. But what I think is fairly universal, no matter where somebody practices, is that they have to be able to demonstrate that that it's legal for them to diagnose substance use disorders and that they have specialized expertise in that area somehow. Now, I could interpret the question a little bit differently and think of it as, well, what does it take to become a certified forensic mental health evaluator with the National Board of Forensic Evaluators? And if that were the case, if the question is about that, then on our international page, let me show you this very briefly here. We recognize in the United States, if you're in the US, then you have to be a licensed mental health professional to be eligible for our certification. But if you are in a country where there isn't licensure for your occupation, then you would have to be able to demonstrate that it is legal for you to diagnose substance use disorders where you're at as part of the certification requirement. And you'd have to be able to show that you have an appropriate graduate degree in a mental health related occupation. And you'd have to have a minimum of 40 hours of either experience providing evaluations for the courts or training related to it. For example, with the 8-hour workshop that we're doing, that's 8 out of the 40 hours right there. And we have a large volume of on-demand webinars that are available for more forensic training. And ISSUP members get a discounted rate for any training, any on-demand webinar training on our website. So those requirements are all here, and I'll paste this link into the, oh, I guess I just realized I wasn't screen sharing when I was showing you this.
Yeah, no,
so
at the moment you're not.
Yeah, I'll post the link, and then people who want to learn more about certification can use that link.
Yes, perfect. And just, yes, so is this link, I can see it now in the chat, Olivia, if you can share it with everyone. Is this, I just wanted to ask you, because again, people are commenting and saying that they're interested in the certification workshop. The link that you had on the flyer that you just showed to us, is that the same link? Or maybe we should also, if we can also have that link in the chat, that would be great. So people can directly go to that from here. And people are also asking, I don't know if Erin, if that's okay, they're also asking for your email address. I know you shared it at the beginning, so I don't know if you want to share it in the chat so people can, if they're interested in the certification workshop, reach out to you directly, if that's okay with you.
Yes, I have put it in the chat. The chat settings only allow me to send things to organizers and panelists, but Olivia has just sent it out to everybody, so we're good.
She's on it, yes. Perfect, great, thank you.
Sure.
Let me see, great. So going back to the questions, we had, yes, we have somebody asking about if you can share what kind of job opportunities are there in the US, actually she's asking for in the United States, for people who have the certification in forensic substance use evaluation.
Okay, great question. Now, there is no state in the United States, to my knowledge, that requires a professional to be a certified forensic mental health evaluator with NBFE in order to be an expert witness in court. What we do have is each state has two different sets of standards that they may follow. Some states follow what we call Daubert standards and some what we call Frye standards. So I'll give you the bottom line. Both sets of standards require you to be able to demonstrate to a judge that you truly are an expert, as evidenced by your training, your education, credentials, and experience. So how do you do that? Well, one way in the United States is you demonstrate that you have a license to practice. And second, that you have specialized training in the case of, for example, if it's substance use evaluations, then specialized training and experience with substance use evaluations. And if you get a credential like ours, then it's very difficult for somebody to allege that you're not an expert, because we would have already required that you have that license, and we've already verified that license as part of the process. And we've ensured that you have completed minimal training in forensic evaluation. You've passed a written examination that's well recognized. You've written a sample report that we showed you how to write. You've defended that report successfully in front of a committee of experts. And so you've essentially been vetted as a professional. And if you've gone through a process like that, it is very difficult for somebody to allege that you truly aren't an expert. So then as far as job opportunities go, there are some people work for agencies that have government contracts. Some people work directly for government agencies, but a lot of people who get certified work in private practices. And then they reach out to attorneys, judges, probation officers, other mental health professionals, make them aware of their services, maybe provide a sample report for them. And we do, as part of the workshop, some training on marketing strategies and some of those opportunities. I can tell you that for me, in the area that I practice in, I've been doing forensic substance abuse evaluations for years, and I don't try to get any referrals anymore, but I have more referrals than I have time for. So there's a shortage of people who are appropriately trained in providing these evaluations in many regions throughout the United States. There are even lawsuits in several states in the US because people are waiting too long for an evaluation and then suing for due process violations because there aren't enough trained evaluators to provide services for them. So it'll vary from region to region. Hopefully I answered the question. The question was about job opportunities, really.
Yes, yeah, great. Good, thank you. So again, more comments, more congratulations. So yes, thank you all for sharing those as well. With a brilliant presentation. And so we will compile all of those comments and then share them with Erin after the webinar. Then we do have another question, and this one is about the justice system. Do you get asked by the justice system to quantify the risk of violence or crime related to substance use in particular individuals? If so, how do you go about that?
Yeah, good question. In the certification workshop, one thing that we do is we cover all the different examples of different kinds of forensic evaluations, and we clarify that nobody does them all. Nobody's an expert on everything, right? Nobody can be an expert on child custody cases and on forensic substance abuse evaluations and on violent potential evaluations and competency evaluations and so on. So what this question deals with, I think, is kind of a fusion between two different kinds of forensic evals: a forensic substance abuse evaluation and a violent potential evaluation, which is an evaluation where we're trying to predict the likelihood that somebody will engage in violence within a specified period of time or something along those lines. If that's true, if I'm understanding that correctly, then I think you would have to be an expert in both of those areas and use tools from both areas. So in violent potential evaluations, there are what are called actuarial assessments, like the HCR20 and the VRAG, for example. And these are tools where you obtain a great deal of information about somebody's history, and then it essentially provides a risk rating for violent offenses based on the data that you've collected. So there is special training for doing violent potential evaluations and actuarial assessments. We actually have one of those trainings on our website in our on-demand webinar section taught by Dr. Tommy Black. It's not an area of expertise for me. I don't do violent potential evaluations, but there are whole books written on how to do violent potential evaluations. And there are tools that are specifically designed and well researched to help you formulate your opinion on those questions.
Great, thank you. I think we've got time for one last question. So aside from the questionnaires and tools that you shared, how do you effectively extract substantial information from people who use drugs that are in denial? So like, were you really having a hard time gathering info from them or even from their families? Do you have any other strategies or approaches that you could share?
Yes, so remember 4 data categories. There's the interview with the client, and essentially with this question, we're not getting much quality information from that category. So the second category is collateral interviews. And based on the question, they're saying, well, yeah, you're also having a hard time getting information from their family members. Okay, but what about from their neighbors? What about from their employer? What about from other people that might be connected to them or have firsthand experience or knowledge? And of course, appropriate consent has to be obtained for doing those interviews with other people. That gets also into the legal question about what consent looks like in your area. But a third category is records reviews. So remember here, you might look for, okay, this person, have they ever been hospitalized before? Have they ever been treated before? Have they been arrested in the past? Can I get all of those records and look for signs or evidence that there might be an alcohol or substance related problem for many of them? I mean, it's amazing how often I'll get somebody's records from a physician and find evidence in those records. Or I'll pull an arrest report and find that when the officers arrived at a scene, that the person's speech was slurred and there was a distinct odor of alcohol, but they denied that it was alcohol related. But then I have this record that suggests otherwise. And then the fourth category would be the tests that I was talking about before, tests like the SASE and urinalysis testing and so forth. So you're getting as much as you can from all 4 categories, and then trying to provide the best conclusion you can. And honestly, there are cases when you do your due diligence and you dig deep in all 4 categories, and you still really don't know. So you would essentially probably offer the conclusion that there's not sufficient evidence to warrant a diagnosis of a substance use disorder at this time based on all the data you've collected. But maybe you found risk factors, factors that suggest that somebody's at risk for a substance-related problem, even if they don't have one, or there's not enough evidence that they have one at this time. And then you might be recommending a preventative measure or an early intervention of some kind. And then sometimes in the course of participating in that level of care, the professional that's working with the person on a more ongoing basis finds additional evidence of a related problem, and then their recommendations for care change.
Excellent, perfect. Thank you so much. I think
Sure.
that's yeah, I think there's more questions, but we've run out of time. And thank you so much for the presentation. And so we will send a follow-up email to all the attendees within the next 48 hours with a link to view the recording, but also with a link to the flyer. We'll attach the flyer because we're hoping that people will sign up for the workshop. And yes, so you have shared your email address. They have your email address. They have the links in the chat. And yes, I don't know, Erin, is there anything from your side that you would like to say?
Yeah, I guess the last thing I'd like to say is I'm really thrilled that you all came here today for this topic, which again, I'm very passionate about and I think is very important. And my hope would be that if you either are providing evaluations for the courts or other legal systems, or you are interested in the future that you find quality training resources to do the work that you are passionate about, and that you do the best job that you can with the information you have available. And I support you all in pursuing that continued growth and education.
Wonderful, thank you so much. And I would just like to thank everyone for joining us today on behalf of ISSUP, and we hope to see you at one of our future webinars. Thank you.